Hello, and thank you for joining us. I'm Patty Powers, and I'm here with Dr. Niall Roche of ValleyCare Health System. He's the Director of Rheumatology there, and we're here to discuss osteoarthritis. So let me just start by asking you exactly, what is osteoarthritis?
Well, osteoarthritis is one of many forms of arthritis. It's the commonest form of arthritis that we see, and the best way to understand it perhaps is to say that it's a degenerative process which primarily affects the cartilage, which helps to lubricate between bones. Now, it's not just the cartilage itself, but there are also changes in the underlying bone, which is really the body's way of trying to repair the damage that's done by losing the cartilage. And also there's some change in the fluid which is inside the joint to help lubricate it, and even in the lining of the joint. So there are a number of changes which occur inside the joint that lead to what we see clinically as osteoarthritis.
And what causes osteoarthritis?
Well, the cause of osteoarthritis is basically unknown. There are essentially two types of osteoarthritis. There's primary osteoarthritis, where we truly don't yet know exactly what's causing the process. We have many clues as to what it might be, for example, age. And then we have secondary causes where there's some preceding problem. For example, let's say somebody who's had repetitive stress, or let's say a skiing injury, or just simply the process of life, that certain joints tend to wear more than others. And in some cases there can be an hereditary component. For example, in women, a certain form of osteoarthritis, for example, affecting the hands and the knees, can be inherited on the maternal side.
I see. Now, what happens to a person's body during osteoarthritis? You mentioned that the cartilage changes, that the bone is changing. What's happening to the person's body?
The body is very, very extraordinarily constructed, as you know, and one of the amazing things is that things which appear simple are actually very, very complex. So, for example, when you use a joint, it's not just that there are two bones that are near each other. There's a whole complex structure called a neuromuscular junction, whereby you have nerves and muscles and bones and cartilage and fluid all working together. So, for example, something as simple as the fluid inside the joint, which, if you like on a hinge in a doorway, helps to lubricate the surfaces. Mm-hmm. When you put force directly downwards, it acts as a cushion. But when the forces are to the side, it acts as something that helps the bones to glide over each other. So changes in these lead to changes in the bone and in the joint that we eventually come to recognize clinically as osteoarthritis.
And if someone's going to have like an injury-induced condition of osteoarthritis, like you mentioned a skiing accident, is that something that will take place right after the injury, or is that something that'll manifest itself 10 years, 20 years later?
Well, depending on the degree of injury, I mean, obviously if you have a major damage, particularly if that's followed by surgery, you can have some changes that occur quite soon. But for many, many people, it's something that happened a long time ago, but the slight changes over time lead to ultimately having an abnormal joint. And something as simple as a malalignment, in other words, a joint which doesn't line up perfectly, as the years pass, as the decades go by, this eventually causes changes in the bone. Of course, once the process starts, it tends to continue and perpetuate itself.
Okay. So you've been talking about as things go on and as time goes by, it sounds like osteoarthritis is only something that affects our older population. Is that correct?
In general, that's true. It's certainly something we see more and more as people get older. It's primarily people who are over 65. Okay. But if you take people who are over the age of 75, if you look at x-rays, at least 80% of those patients have changes on their x-rays. So what I sometimes tell my patients is, if you live long enough, you're going to get osteoarthritis. In some patients, however, it can occur much younger than this.
I see. And is it found more in men or more in women?
In general, it's far more commonly in women. There are a couple of...
Well, that's not fair.
It's like many, many conditions, it's more common in women. Now, there's one form, for example, primary osteoarthritis of the hip can be seen more often in men. But sometimes that's occupational related. For example, joints which we would not normally see osteoarthritis, let's say, for example, the shoulder or ankle, could get involved if a person has, say, played a lot of football or was driving a bus or something, or using those joints abnormally.
Okay. And then what about races? Are some races more affected than others by osteoarthritis?
Can affect all over the world. Everyone's affected. This is an equal opportunity condition.
How kind. So you said that it can happen to anybody. What's a typical profile? I mean, if women can get it, men can get it, any race.
Yeah.
Is it normally someone, you said, over 65?
And what else? I see people every day, and I suppose a typical patient will be perhaps a middle-aged to slightly older woman who may present with abnormal changes in her hands or knees. That's a very common presentation. It often involves the first joint of the toe, where the big toe connects to the foot. So that's kind of typical places, and also the spine can be involved.
Okay, and part of my question as well, I apologize, is it normally found in someone who's been an athlete all their life, someone who's had a rather sedentary life, or does it run the gamut of that population as well?
Anybody can get it. I'm afraid if you're very active or very inactive, you're probably at more risk. In other words, people who people who use their bodies a lot might actually wear their joints more. That makes some sense. But perhaps what people don't think as much is that that moderate exercise can not only help with osteoarthritis, but it can actually help prevent it. And the reason for that is that when the muscles around a joint are healthy and strong, they lessen the forces on the joint itself. Say around the knee, you've got big muscles in the thigh and in the lower leg, and if they're strong and you use them regularly, you're balanced, you're strong, and there's less actual abnormal damage to the joint as the years go by.
Okay.
So moderate exercise is very good, particularly, say, for example, something like swimming, which doesn't put a direct force on the knee.
On anything at all.
Yeah.
Okay.
Yeah.
Now, where will someone's osteoarthritis manifest itself first?
In different patients, it will manifest in different places. A typical presentation would be a woman who notices, say in middle age, that some of the joints of her fingers become abnormal.
I believe you brought a video.
There's a slide, actually.
Okay.
We have a slide. Now, this is a good example of a patient who has involvement of her hands. And what you notice here is that certain of the small joints of the hands, for example, if you look at the small joints that are just close to the nails, you see there's quite a lot of changes in those hands, in those joints, and also in the joints which are just up from that. What's interesting is the joints that are part of the hand itself are relatively spared. And this is a typical finding in osteoarthritis. One of the ways in which rheumatologists can diagnose different kinds of arthritis is by the pattern of joint involvement. So this involves the hands. If you pay very close attention to where the thumb joins the wrist, you can see a slight little bump there, and that's a very favored place for osteoarthritis to affect.
Are you talking about right here?
Yes, a little higher up, right here where it joins the wrist. There's a little bump just there, and that's the carpal metacarpal joint. And what's important about it, first of all, it's a favorite spot of osteoarthritis. And unfortunately, it's very important in certain functions, like opening jars and bottles and using knives and things. So that's a place we look for that. Now, other parts of the body where we might find joint involvement would be, for example, in the neck or lumbar spine. And very typically, in a patient such as this, we'll also find involvement of the knees. Now, one of the questions this raises is, you asked, does everybody get the same thing, or who gets this? I remember one lady who was 85 saying one day she was about to be reviewed for potential knee replacement, and she said to the surgeon, so she was about to have her right knee replaced, and she said, so why is my knee so bad? And he said, that knee is 85 years old, and she said, so is the other one, and it's fine. So I think
it kind of does beg the question, why here and why not there, and why here and why not here?
It's some subtle things. We think that, for example, very small malalignments, and malalignment means that the bones are not lined up correctly. And it's over the years, it's with the passage of, obviously by 85 years, even a small abnormality, which would be perhaps not even detectable in childhood, over the years causes abnormal forces on the knee, and they accelerate over time, and that's what leads that joint to become involved.
I see. Does someone ever have osteoarthritis in just one place on their body, or do they usually have it in just one place on their body? Or once they get to this point, is it usually, my left hand, my right knee, my left ankle kind of thing?
All of the above.
Okay.
A person can have one joint, they can have a number of joints, and sometimes there's one joint that bothers them. For example, some people, when I examine them, you look at all the joints, obviously, and the patient may be complaining of one particular joint, but when we go examine them, we find other joints are involved as well, and perhaps a couple of years later, the other knee will, for example, become symptomatic.
I see. So as far as risk factors for osteoarthritis are concerned, we've spoken about age, and we've spoken about trauma and injury. What other risk factors are there?
Well, one other common risk factor is being overweight. If you're overweight, this puts an abnormal strain on the joints. Now, we know, for example, this particularly affects the knees.
I would imagine.
But being overweight doesn't affect all your joints. For example, obviously the hands, but strangely enough, the wrists or ankles tend not to be affected. So it shows up in certain places. So being overweight can be a factor. Sometimes if you have another kind of arthritis, for example, if you have rheumatoid arthritis, the damage to the joint, again, I guess it falls under trauma, but this is a special kind of trauma. It's due to another kind of arthritis. which I guess raises the question, can you have more than one
That
kind
was
of
my
arthritis
next question.
at once? And you can. Unfortunately, if you have rheumatoid arthritis or other kinds of arthritis, for example, gout, you'll frequently find the patient also has osteoarthritis. Further, some certain kinds of abnormalities, for example, if patients are born with congenital abnormalities of the hip or whatever, in childhood this may not be a major problem, but it may show up later in life. And there are certain diseases, they're a little bit complicated, but certain diseases which involve metabolism like copper storage and iron storage, they can actually accelerate the process of osteoarthritis. We're not exactly sure why, but this is something we do see from time to time. And patients, for example, who have hemophilia, have damage to joints. Again, I guess it's a particular kind of trauma, but they get blood in joints, which accelerates the development of arthritis.
I see. So what are the symptoms? I mean, what's going to send someone to you saying, I think I might have osteoarthritis? Is it just because they're hurting? Where are they hurting? Or is it because they really had no idea they had this and their general practitioner just said, oh, you need to see a rheumatologist? I
think most patients become aware of this when they start to hurt. What they notice is that there's usually an insidious onset of pain. So it's just, they first begin to notice perhaps that with overuse, if they walk a long way or do certain unaccustomed activities, they complain of pain. The other big complaint is stiffness. Now, they're often a little stiff in the morning, but it doesn't last too long. When they get up and get limber, they have a shower, they feel fine. But let's say later in the afternoon, they sit down for a couple of hours or they're driving and they get out of the car. Then they notice that the first couple of steps are really difficult and slow. And after maybe 5 steps, they can actually walk normally. So stiffness is one thing. Also, you may see bumps, or people often say my fingers are changing. So just as in the slide we showed earlier, a patient might notice that, and sometimes those bumps form relatively painlessly, surprisingly painlessly sometimes, but the patient wants to know why, and often they'll have known this was something that their mother or grandmother had. Interesting enough, even in patients where these joints are painful, the process in a certain sense sort of burns out, and by that I mean that when these little bumps are fully formed, often you've got hands which look bad but function very well. And that's reassuring for patients because, when they see their hands changing, they worry, will they be able to, open jars and bottles and write letters and do whatever they want to do? And for the most part, they can, which is good news.
Now let's talk about diagnosis. So somebody has, let's say their hands are beginning to be malformed or their knee is hurting like crazy and they come in to see you. How do you diagnose osteoarthritis versus osteoporosis versus gout versus other things?
Well, it's really due to pattern recognition. It's a clinical diagnosis, and by that I mean it's something that somebody who sees a lot of arthritis patients, I see approximately 18 arthritis patients a day, 9 patients in the morning and 9 in the afternoon. So obviously as time goes by, and with training obviously to start out with, it becomes relatively straightforward to diagnose these common forms of arthritis. And so it's usually something the doctor will, you come in, you get examined, you see these changes. You may find changes, for example, in the knee. When you move the knee, there are certain signs that help you recognize there are changes. You might find some bony swelling. Swelling is a common thing in many kinds of arthritis, but here it's often the bone itself, which is swelling in response to the change in the cartilage. And x-rays can be very helpful. I might just mention, though, that it's strange. I still am surprised at times that patients can complain of a lot of pain. You do x-rays, and the x-rays are surprisingly good. And the converse is true. Sometimes, for whatever reason, you might do x-rays of somebody's knees, and the x-rays are terrible. And you come back to the patient and say, how are your knees? And they say, oh, they bother me going up the stairs now and again, but not really.
And you're looking at this saying, this person's kind of a train wreck?
I'm looking at the x-rays and saying, I can't believe that it's that asymptomatic for that patient. So the implications for a given patient are very different. And finally, people often want to know about blood tests. And again, blood tests are very useful in diagnosing different forms of arthritis. But for the most part, blood tests are normal in patients with osteoarthritis. And also, even if you take fluid out of a joint, which is inflamed or which has some degree of collection of fluid, sometimes abnormal fluid will accumulate, very often this fluid is surprisingly normal. Unlike, say, a patient with rheumatoid arthritis. So any of these things can be helpful in establishing the diagnosis.
Okay.
Once you have the diagnosis, I'm afraid it means you have the diagnosis for life.
Dr. Roche, I'd like to talk to you about the treatment of osteoarthritis, but before we get too far, I would like to ask you about prevention of the disease in the first place.
Well, certain things it's hard to do anything about, for example, the aging process, but there are other things you can do something about. It turns out that moderate exercise is actually very, very beneficial. Now, if the body was simply a machine, you know, the more you use a machine or the more you drive your car, the more it wears out. But the body being a living system, moderate exercise on a regular basis actually can be very important in preventing, for example, osteoarthritis of the knee. And even patients who have symptoms will find that if they start a gentle exercise program, that they can reduce their symptoms considerably. If you're overweight, that can be very important for some patients, for example, who have osteoarthritis of the knee. And finally, avoiding unusual trauma. I mean, it's certain things, for example, let's say a lot of stairs for some patients. If they're, you know, some people like to exercise by stair climbing. And if you have some arthritis of your knees, you need to avoid things like that. You're only going to accelerate the process.
Okay. Now, there's so much focus these days on occupational therapy. Is repetitive use of fingers on keyboards and things like that, is that something that leads to osteoarthritis, or is that something that leads to a different type of arthritis?
Generally speaking, using keyboards and so on would have very little effect on osteoarthritis. That's something that's far more likely to be due to heredity.
I see.
Yeah, so now the base of the thumb's a little different. If you use your hands a lot for, you know, let's say somebody who's doing a lot of sewing or something, I don't know if anybody sews anymore, but if you do a lot of activities that involve or repetitive motion, say in a factory, you could find somebody who wears out the joint at the base of the thumb.
Okay. So somebody has been into your office, they've been diagnosed, yes indeed, you have osteoarthritis. Now what? What can you do for them?
Well, the two primary goals really is, first of all, to relieve pain and discomfort, and secondly, to maintain function. So these are the two goals that guide everything else we do.
And can you ever make it go away completely? Can you ever completely reverse somebody's having osteoarthritis?
It's not really curable.
Not even you?
Not even me, I'm afraid. No, it's not. I think the best we can hope for at the moment is to minimize the impact that it has on somebody.
Okay.
And I think, in speaking of that, perhaps the first thing that helps to minimize the impact on somebody is to educate the patient and their family as to what kind of arthritis this is. Because when people experience joint pain and stiffness, they may have seen patients who have very severe arthritis, let's say rheumatoid arthritis, or may know somebody who has this, and they're very concerned and very anxious that that's what's going to happen, that they'll become incapacitated, they won't be able to, you know, do their daily activities. But for the most part, that's not something that it's a very slow-moving process, and it often takes decades before you see changes. And if you modify your lifestyle, if you use the right treatment, you can minimize the impact that it has.
Okay.
So we usually begin with the very simple things first. So we mentioned pain as being a primary goal. So very simple analgesics can work very well. And this is often a surprise to people. They come to me, I'm a specialist, and they think I'm going to send them out with some very fancy medication. And I say to them, I think for you, that the best thing to start with is a couple of extra strength Tylenol twice a day.
And that seems almost like a disappointment at that point, huh?
Almost. But you know, if you're thinking long term, you have to remember that if you take medications every day, just as arthritis has an effect on the body, if you take drugs like, say, Motrin, Aleve, or Advil, or other stronger non-steroidal drugs, they can upset the stomach, they may cause bleeding, and if you take them long enough, and here we could be talking 10 or 20 years, you can actually damage your kidneys. Now, you know, I often say to patients when they look at me and say, can I have something stronger? I say, well, you must remember, it doesn't matter how painful your knees get or your back is, that's not going to kill you. But if you're unlucky enough to start bleeding internally, that's a whole different level of risk. So you have to kind of moderate the risk with the level of what you're trying to treat. And the important point is that it works very well. Now, if people take a couple of Tylenol now and again, it often doesn't work. But if they take it every morning and every night, and we've new guidelines now which state that the maximum amount of Tylenol you should take in a day is 1,000 milligrams 3 times a day.
Okay.
So we start out with the simple things. Patients report back. Hopefully they're already doing well. If not, we move to slightly stronger medications. Often I would use something like Tramadol, sometimes known as Ultram, that's the brand name. And that's a pill you can take once a day. And in addition, if you add in a couple of Tylenol, they become like super Tylenol. They work much better. So for the vast majority, let's say more than 70% of patients, that's all they need.
And will they be able to resume their normal, you know, I used to love to run, I used to love this and that, you know, having the osteoarthritis and taking the drug to alleviate the pain, will they be able to continue with those activities, or do they still need to curtail their activities?
I think the goal is to help people lead as normal in life as possible.
Okay.
Sometimes you have to modify things a little. I mean, people may have to moderate their, black diamond skiing or whatever.
Doubles tennis, not singles tennis.
Exactly.
Okay.
But usually people, as life goes on, this is less of an issue for most people as they're getting older. What you're trying to do is get them to do some exercise. It's rare that I'm trying to hold somebody back from doing too much.
Okay.
We also have certain things that can be used right on the joint. For example, Voltaren gel is something that can be applied directly to the joint. And this is terrific. For example, especially if a small joint, let's say a small joint in the hand or a couple of joints, you can put the medicine where the problem is. And that's one of the great goals of medicine, is that you can put something in and it's not affecting the rest of the body. It just gives you relief where you need it.
Is that a newer product? I've not heard of that before.
It's something relatively new. It's been used in Europe for a long time, but it's relatively new here in the States.
Okay.
And now there are a couple of new formulations which are slightly stronger of the same medication, which are becoming available. And people can use sometimes patches or strips, things like that. The gel is good because when a joint is moving, one of the problems with patches or strips of medication is that they can come off when you move them. But a gel, obviously, it's absorbed, it evaporates, and it goes into the joint, and it can be very helpful.
Okay.
Sometimes, again, speaking of local treatment, we can do what's called viscosupplementation, a very long word for saying a very simple thing. We take out the bad fluid that is kind of accumulated in the joint, and we replace it with artificial synovial fluid. So it's like putting in the synovial fluid of an 18-year-old. And sometimes that's what I say to people and say, so you can expect,
to feel like you're 18 again.
Almost. 18 again. And this, for many patients, that will buy time. I mean, especially if somebody's considering something like surgery, we would recommend try the simple things first. And if they don't work, then you always have other options down the road.
So this is done via an extraction and then an injection to follow?
Yeah.
And how often would that need to be repeated?
Well, initially, many of these were given over several weeks. Like you come in every week, say 3 weeks in a row, and have this procedure repeated. Now they've come up with formulations that can be done simply once.
Oh.
And obviously, if you're talking about putting a needle in somebody's knee, we like to think that we're pretty gentle and it's not too traumatic. But obviously, given a choice, most people prefer to do it once.
Once is good, yeah.
And it often works for over a year.
Oh, wow.
Yeah,
okay.
so they have a year of relatively pain-free joint, which is very effective, and it can change your life quite a bit. I think also lifestyle changes can be important. We encourage people, if they're overweight, to lose weight. That's very important because it literally takes the pressure off the joints which are affected. As I mentioned earlier, moderate exercise is extremely beneficial. It not only improves the actual structure of the joint, but it actually can slow the progression of osteoarthritis. And it builds strength, and it can actually even relieve pain. There are natural pain relievers which kick in. I heard, just as before I came here today, I was listening to something. Charlie Rose was interviewing a gentleman about the subject of habits and talking about the subject of exercise, and saying that when people are starting to exercise, a very good thing to do when you come back from exercise, and this is a surprise, is to eat a small piece of chocolate or have something you really like.
Oh, I do that already.
Oh, you do? You're way ahead.
It's my reward.
Well, it turns out that kicks in the reward center, especially initially when people have to motivate themselves. They come back from exercise and they can have something that they like. And in time, people become addicted to the effects of exercise itself. They feel better, they have more energy, they have less pain, and that motivates them to keep going. So the important is to get them going. And if you get them going often, they'll keep going.
I like this particular guy. What's his name? Charlie Ray?
Well, Charlie was interviewing the gentleman who was talking about the subject of habits and how they're formed and how they're changed.
Okay, good. And then let's talk a little bit about physical therapy and occupational therapy.
I think they're both very, very important. Again, getting people motivated. I mean, if you start them out where somebody's there to help them and to show them how to do it right. I mean, that you can do exercise that's beneficial, and you can sometimes do exercise that actually can make the situation worse. So a physical therapist has great expertise in knowing how can we work around the problems. Okay, the left knee is the problem. How should this person walk? Should they be doing water exercise? Should they do they need a cane? Do they need an assistive device? If perhaps you wear a simple knee support, and a knee support is rather like a stocking. And if you think about it, because it's completely mobile, it's not giving much support in the sense of, like, say, a plaster cast would. But what it does is it gives feedback to the brain. It tells the brain exactly where the joint is in space, so that helps the person to place their foot correctly. You know the phrase, look before you leap. Mm-hmm. I think this illustrates very well what we're talking about here, that if before you jump off something, you look down, what happens is your brain calculates how much tension, how much do I need to tense these muscles to minimize the impact. And that's why, you know, obviously cats can jump from very great heights. They're very good at this. And they basically are like springs. So you become almost like a human spring. The converse is true, that let's say you're walking at dusk and there's a very small change in the pavement that you don't notice it. And your foot goes down on the little depression. But you get quite a jolt, even though you look back and think, well, how did I get such a jolt? The reason is you weren't expecting it. So joints are very dynamic things. We're inclined to think of them as just where two bones meet, but there's so much more to it than just that. And again, speaking of occupational therapy, there are lots of things you can use for your hands. For example, they now have wonderful attachments you can put that help you open jars and bottles, that help you use knives, that help you use scissors. I mean, for people who have limitations, these are very useful to know about.
Okay, and then let's fast forward a little bit. So we've got, we've got the medicines, we've got the drugs, we've got the therapies. When all of that is no longer enough and we come to surgery, what happens then?
There are a number of surgical options. In general, my advice to people is to try and hold off if they can on surgery, because it's always nice to have something in reserve. Having said that, sometimes you're always weighing up pluses and minuses. And one of the things you're weighing up is if we wait too long, the patient's going to be that much older. Perhaps they have other medical conditions which might be getting worse. They need their strength and resilience to recover from the surgery. So this is a very individual decision, and the decision is best made by the patient themselves, because particularly if things don't go as well. I mean, normally the results are superb. We get great results and it can be life-changing. But if things don't go exactly according to plan, if the person feels they made the decision themselves, they're a lot happier with the outcome. They're better or able to deal with the fact that they got, something happened, they, got an infection or something. They'll deal with it much better if they know they weren't managing too well without it. And there are different forms of surgery. It might just mean going and cleaning out the joint, taking out any debris. It might be realigning the joint a little bit or replacing the joint. And we do over 150,000 knee replacements in the United States every year, over 200,000 hip replacements. So I never like to say surgery is routine, because I always look on surgery as being a fairly major life event. But we do lots of them, and every time they're done, we learn something, and basically they get better and better.
And on that note, as far as learning something, because we just have one more moment, I wanted to ask you about the future of this disease and where you see it headed.
Well, I think two important points about that. First of all, we're going to see a lot more of it, and that's because people are living longer. So as people live longer, they're more prone to getting osteoarthritis. And this also means they'll need to have more surgeries in the future. I'm happy to say, however, that there's a lot of research going on in the world of osteoarthritis right now. They're looking at new molecules, things like metalloproteinases. We haven't heard too much about them in the public yet, but I promise you, if they turn out to be promising, there's something that we'll hear lots about. Because we know that one of the major problems in osteoarthritis is cartilage. People are doing a lot of work on cartilage, for example, taking out stem cells and seeing can you reimplant them in artificial cartilage. You can, for example, have webs of tissue in which you can regrow the patient's stem cells and reline the joint. Again, we have to choose our patients very carefully, and we're looking a little bit ahead here. But I think the future, I'm optimistic that we already have come a long way, and we're going to go a lot further, hopefully before you and I actually need to avail of these things.
I like that idea. Thank you so much for sharing this information with us, and thank you for joining us. I hope you learned as much today as I did about osteoarthritis.